I'm Swapnil Hiremath. I'm a nephrologist from the University of Ottawa in Canada. Joining me today is my co-moderator, Dr. Rebecca Ellis.
Hello, I am a nurse scientist and associate professor at Indiana University.
And our special guest today is Dr. Niteesh Choudhry.
Thanks for having me. I am a professor of medicine at Harvard Medical School and the Harvard School of Public Health. I'm an internal medicine general internist hospitalist by clinical practice.
We talk about shared decision-making. And when I'm looking at someone who has high blood pressure and I'm trying to convince them you should be taking your pills, I'm often talking about high blood pressure increases your risk of stroke by so many percentage, and 10 years down the line, or heart failure or kidney disease or what have you. Patients may have a different perspective, right? Their goals and my goals may not be aligning. Do you have any strategies about how we approach these discussions?
One of the first ways to begin that conversation is to ask what our patients' goals are. And that is a good starting point, especially when there is an opportunity to explore what their perceptions are about taking medication. It's very difficult to have a focus on prescribing medication when there are beliefs by the patient that they don't want to take those medications. Beginning there is a really good place to start, and exploring what potential thoughts are behind why there is a barrier to taking medications or doing other approaches.
And yet what we do as evidence-based prescribers, in particular in cardiology, it's actually quite ironic. There are more and more medications which are all evidence-based. So we can think about heart failure and GDMT and heart failure with reduced ejection fraction, GDMT and acute coronary syndrome. And we quickly come to this place where a patient could very legitimately be on 15 or 20 evidence-based medications. And now, if we imagine that we don't like pills and maybe we take a few, whereas some patients' experience is that they take many, many pills, it's perhaps not at all surprising that they would find it unpalatable, just like we do. I think the idea of negotiation is really the right construct, but not because we're trying to necessarily convince them that we're right, but that we want to understand what they would like. And the reasons people may not want to may, in some cases, be things we can address. So if they, for example, in the case of hypertension, my patients have long told me, I don't want to become addicted to my antihypertensives. My blood pressure is better. I can stop taking it now. Those are things that we might address. And so understanding their motivations will help with that. Behavioral interviewing techniques like motivational interviewing, or versions of that like brief negotiated interviewing, we're eliciting patients' preferences, providing potential solutions, eliciting their reactions to those solutions may well be more effective ways to engage them and empower them to take control of their own health.